Welcome, everyone, to today's pulmonary critical care and sleep medicine grand rounds. My name is Clara Yagi. I'm in the section of pulmonary critical care and sleep medicine, and it is my distinct pleasure to introduce Dr. Akhiwu for her presentation today. Dr. Ofure Akhiwu completed her undergraduate studies at Canisius College in Buffalo, New York, before earning a combined MD, MPH at Tulane University School of Medicine, where she focused her research training in community health. She then went on to complete her internal medicine internship and residency at Johns Hopkins, the Bayview campus, and after which we were very fortunate to recruit her to Yale for her fellowship training in pulmonary and critical care medicine. Now in her third year of fellowship, Dr. Akhiwu is serving as a chief fellow and has been a trainee in our section's T32 research training program. And over the past year and a half, I've had the privilege of mentoring her as she's developed a research program in two major areas. One is she has been examining sex differences in the opioid use disorder pandemic, with a particular focus on the influence of sleep deficiency on recurrent non-prescribed opioid use. And she's already generated some very important insights and observations from that work. Her second domain, she's actively contributing in recruiting and following up and serving as a co-investigator on an NIH R01 led by Dr. Nancy Redeker at the University of Connecticut, a collaborator of mine, where they are investigating sleep health phenotypes among Black and Latina women of childbearing age, which is directly related to the talk she'll be giving us today. And it's really through this outstanding work on these two projects that Dr. Akhiwu was selected for the prestigious ATS Aspire Fellowship Award, which provides additional mentorship and research funding support for pulmonary and critical care fellows interested in pursuing an academic career in sleep medicine, an area that she is deeply committed to. So today she will be presenting on a topic that I think lies at the intersection of her clinical and research passions. Her talk is entitled Bridging the Gap: Maternal Obstructive Sleep Apnea as a Modifiable Driver of Adverse Pregnancy Outcomes. And a special welcome to our prospective fellows listening in today. And Ofure, the podium is yours.
Thank you so much, Dr. Yagi, for the kind introduction. At some point in time, I was like, is this me? But thank you very much for the introduction. And thank you for everyone for showing up. I know you have a very busy schedule and a very busy day, but thank you for taking the time out to come. This topic is very near and dear to my heart. I've always been interested in women's health, even before I became a mother myself. Almost did OB-GYN, but I really preferred rounding for several hours. Recently, personally experiencing pregnancy and childbirth, it has even become closer to my heart. The importance of maternal health, especially maternal health, maternal sleep health, has been at the forefront of my mind. I hope this presentation sheds some light about the importance of maternal health, the effects of sleep deficiencies and disorders, and ways that we can address these deficiencies. First off, I have the disclosures. So this is how you can get your CME credit, and I'm also a part of the ATS Aspire Award. This is a funded grant by the ATS, and it's meant to help support my research and provide mentorship for pulmonary and critical care fellows interested in sleep medicine. For the learning objectives, at the end of this presentation, you should be able to describe the prevalence, pathophysiology, and clinical presentation of obstructive sleep apnea in pregnancy. I want you to be able to recognize maternal and fetal complications associated with untreated maternal OSA, and identify populations that are disproportionately affected. I'm going to be discussing current strategies for screening, diagnosis, management of OSA during pregnancy. And we're also going to evaluate opportunities to integrate sleep health into maternal care as means of improving outcomes. So this is how I'm going to outline my case. I'll outline my talk. We're going to start with the brief case presentation. Then we'll talk about epidemiology of pregnancy-related adverse outcomes in the United States. Then we'll discuss obstructive sleep apnea, the pathophysiology, and sex and racial disparities. And then we'll talk about OSA in pregnancy and its effects on maternal and fetal health. We'll talk again about guidelines, screening tools, and then something close to my heart is postpartum sleep deprivation. So we have to talk about that. And then we'll touch on gaps in research and ongoing research momentum in this topic. So first off, the case. This is a 32-year-old woman, G4P0120. I'm going to explain what that means. So she's been pregnant 4 times. She hasn't had any live births. She's had 1 birth that ended up in fetal demise and 2 miscarriages. She has a history of chronic hypertension, class 2 obesity, and a BMI, class 3 obesity, sorry, and a BMI of 50. Her last pregnancy was complicated by fetal growth restriction, HELP syndrome, placenta abruption, and subsequent intrauterine fetal demise at 28 weeks. She has a history of mild OSA with an AHI of 7.6. This was found out before she got pregnant, and it was done, the sleep study was done at an outside facility in 2019. She went untreated. This pregnancy, our goal is to address all the possible modifiable risk factors for this patient, and specifically discuss the treatment for her sleep apnea. So let's talk about epidemiology of pregnancy-related adverse outcomes in the United States, because the numbers are striking. I like to talk in numbers. So pregnancy-related mortality in the United States is elevated. Between 2018 and 2022, there were 6,283 pregnancy-related deaths in the United States. I want us to take a minute to pause and think about that number. That's a very high number of women who it was meant to be the happiest days of their life, and it ended in death. This is not counting deaths from car accidents, suicide, or homicide. There was an upward trend from 2018 to 2022, and as you can see in this graph, there's a big spike between 2022 and 2021. This, in part, is attributed to the COVID pandemic. These rates are gradually coming down, but not uniformly for every race and ethnicity. There's also a significant geographic variation, and we'll talk about that in the next slide. As we can see in this map, Alabama has a significantly higher crude mortality rate of 60 deaths per 100,000. In contrast, California has the lowest at 18.5 deaths per 100,000. Connecticut falls a little bit in the middle at 28.8 deaths per 100,000 live births. Some of these geographic variations may be explained in part by ethnicity, racial disparities, and if the national rate was the same as the lowest states, 2,600 pregnancy-related deaths would have been avoided between 2018 and 2022. So let's look more in depth into the racial differences in maternal mortality rates. What this graph shows is that racial disparities in pregnancy-related deaths do exist. This is a CDC report of pregnancy-related deaths in 2023 comparing data from 2022. We can see that the maternal mortality rate is highest in Black women, and this rate has increased between 2022 and 2023 in this population, while rates have decreased in every other races and ethnicities. It's important to note that there are also disparities in fetal health outcomes, which we will also discuss in the next slide. Majority of the events that are related to the adverse, majority of these deaths are related to adverse cardiometabolic health outcomes, like preeclampsia, eclampsia, obesity, and pregnancy. For racial differences in fetal health outcomes, as we can see by this study done by Pratt et al., Black women experience twice the rate of fetal mortality compared to white women. Black mothers also suffer preterm births and have fetuses with higher prevalence of being small for gestational age. In summary, maternal mortality rate is elevated in the United States. There is a state-by-state variability. Mortality rate is decreasing for every other race and ethnicity except for Black women. And there's also a racial difference in fetal health outcomes. Cardiometabolic diseases is a leading cause of maternal mortality, and could maternal sleep health, specifically sleep-disordered breathing, be a missing link to improve maternal health outcomes? So we're going to talk about that in the next section. So just to reorient us, we've talked about our case, we've done the epidemiology of pregnancy-related adverse outcomes, and now we're going to talk about obstructive sleep apnea. So what is obstructive sleep apnea? OSA is characterized by repeated episodes of partial hypopnea or complete apnea, airway obstruction caused by airway collapse during sleep for at least 10 seconds. We calculate something called the AHI, which is the frequency count of the number of apneas and hypopneas per hour. We have categories for AHIs: mild, moderate, and severe. For mild, it's AHI of 5 to 15, moderate 15 to 30, and severe greater than 30. For our patient, she had an AHI of 7.6, which made her fall in the category of mild. When we applied these definitions, we see an enormous prevalence of this disease. An estimated 1 billion people in the world have OSA. It is a cause of economic and social burden, leading to significant healthcare utilization, motor vehicle accidents, workplace accidents, amongst other things. It has various health implications, specifically associated with increased cardiometabolic risks and physiological effects. The pathogenesis of sleep apnea is very, very complex. And I feel like during this research for this presentation, I learned so much about how heterogeneous it is and how complex it is. For a long time, we thought OSA was just based on anatomic factors, but there are also non-anatomic traits that predispose people to obstructive sleep apnea. Even within the anatomic predisposition, there is a complex mechanism behind sleep apnea. There are opposing stroke balancing forces working together to keep the airway patent. For promotion of airway patency, we have the pharyngeal dilator muscles and lung volumes. And for promotion of airway collapse, we have negative pressure of inspiration and extraluminary positive pressure. For these anatomic factors, the concepts of critical closing pressure arose. This is the pressure at which the upper airway completely closes leading to a cessation of airflow. For a highly collapsible airway, it doesn't take a lot of negative pressure to close it. In contrast, those who have stable upper airway, it takes more negative pressure. So we can see like a heterogeneity even in the anatomic predispositions for obstructive sleep apnea. Now we're going to talk about non-anatomic physiological traits that predispose people to sleep apnea. There are a lot of non-anatomic traits. At least 50-something% of people have these risk factors that predispose them to sleep apnea. We have something called high loop gain, and this is simply how sensitive a person is to an elevated CO2. Poor muscle response, and something called arousal threshold that I'm going to go back to over and over again, because this is very important for our talk. Arousal threshold is how much breathing disturbance it takes to wake someone up from sleep. If you have a low arousal threshold, it's easier to be woken up from sleep. These non-anatomic traits can be measured during sleep labs, in-lab sleep studies. So it's very important. Here at Yale, our very own Dr. Wan describes sex differences in the non-anatomic traits predisposing people to sleep apnea. So this is just more slides about the non-anatomic traits. So Dr. Wan specifically found that women have a lower arousal threshold and are more likely to have something called comorbid insomnia and sleep apnea, COMISA. This low arousal threshold could be in part explain adherence to CPAP use. Our very own Dr. Zinchuk described how lower arousal thresholds is associated with poor CPAP use. In this study, he showed that the magnitude of this effect was actually very striking, and he predicted adherence not just at 1 month, but at 24 months after. So if you're more likely to be woken up from sleep or from like from sleep disturbances or episodes of apnea, you're also more likely to wake up from the CPAP. So this was very important. So in general, for women who have sleep apnea, they're less likely to report snoring, less likely to report witness apneas, and are likely to report fatigue, headaches, and depression. This leads to a different diagnostic pathway and underdiagnosis. There is a profound impact also at menopause or after menopause. OSA prevalence triples post-menopause, and this causes increased cardiovascular risks after menopause. They also have less hypoxic preconditioning, so there's less time for your body to get used to the fact that you have OSA, which leads to greater morbidity. There are racial differences in OSA as well. In the Cleveland family study, African Americans had higher odds of sleep-disordered breathing compared to Caucasians, even after adjusting for confounders like obesity, suggesting it's not explained by obesity alone, which we've talked about in our previous slides. It's very complex. There are anatomic and non-anatomic physiological factors that predispose a person to sleep apnea. And so we have to keep that in mind. These risks appear early in life and persist into older age. So how does OSA lead to adverse cardiometabolic risks? So this slide is very important. When the upper airway gets obstructed, there is associated hypoxia, hypercapnia, increase in interthoracic pressure, and arousals, leading to an increase in sympathetic response. This causes vasoconstriction, tachycardia, oxidative stress, inflammation, metabolic dysregulation, so much. And in the long term, when you experience this over and over again, it leads to chronic hypertension, congestive heart failure, arrhythmias, even cerebrovascular accidents, and diabetes. Could the same pathophysiology contribute to the heightened risk for maternal cardiometabolic health outcomes and mortality? This is something that we're going to discuss further. So again, my outline so that I can align everybody to where we are at. So we've talked about the case, epidemiology, we've talked about obstructive sleep apnea, and we've defined it. And then we're now going to go into the topic of OSA in pregnancy and its impact on maternal and fetal health outcomes. Does anyone have any questions, any pause? I just want to pause for a little bit. Any statements? Okay, all right. So next up, obstructive sleep apnea in pregnancy, the numbers. There is a high prevalence of obstructive sleep apnea in pregnancy. There's a 2 to 3 times higher prevalence in pregnancy, and it increases with trimester. In the first trimester, about 10% of people are diagnosed with sleep apnea. In the third trimester, it's about 20% of people. High maternal age and first trimester BMI are predictors of developing OSA later in pregnancy. Well, as we've talked about before, there are other non-anatomic predispositions that haven't been studied yet. Snoring, a phenomenon associated with OSA, is significantly more common in pregnancy. Significantly more common. I'm going to say this one more time. Significantly more common in pregnancy. I'm going to pause a little bit for a personal funny story. Every time I beat my chest and say I never, ever, ever, ever snore. And in third trimester, my husband took videos of me snoring all the time. And, I didn't feel like I had any risk factors. And I felt like I was very healthy throughout the pregnancy, and I was exercising and doing everything. But here I am still snoring. Never got a sleep study, but just to show how common this is. About 40% of pregnant women say that in third trimester, they do snore. So what's the proposed pathophysiology of obstructive sleep apnea in pregnancy? A lot is happening. Elevated progesterone increases upper airway collapsibility. Higher estrogen causes the swelling of the nose and the nasal airways and the throat tissues. And then we have anatomical changes, including increased fat deposition in the neck and in the thorax, around the thoracic cavity. And we have fluid retention, especially in late pregnancy. We also have decreased lung volume, which, as we've seen before, lung volume does play a role in airway patency. Obesity in pregnancy is also a risk factor, but we've discussed again and again that there are other non-anatomic physiological risk factors that might put someone at risk for obstructive sleep apnea. Racial and ethnic disparities in maternal OSA. Not a lot of studies have been done on this topic. In early pregnancy, non-Hispanic Black women are twice as likely to have sleep-disordered breathing compared to non-Hispanic white women. Non-Hispanic Black women also have more severe disease with higher AHI. Analysis, again, from the Cleveland study suggested that body weight is not the only explanation for this difference in AHIs. So, we do, again, know that there is a racial disparity, but anatomic factors is not the only thing that might be playing a part. And so let's talk a little bit about obstructive sleep apnea in pregnancy and what the risks are for the mothers and for fetal outcomes. Data does suggest sleep apnea in pregnancy is a risk factor for adverse maternal outcomes. This study was done by a former Yale fellow. She's now at Brown, Dr. Gada Boujreli. And it showed that obstructive sleep apnea in pregnancy was associated with an increased risk for preeclampsia, gestational hypertension, and eclampsia. It also showed an increased risk for gestational diabetes, even after adjusting for obesity. The same study showed an increased risk of severe complications, including cardiomyopathy, CHF, and the need for a hysterectomy. There was increased ICU admission and hospital stays. So we can see that for women with obstructive sleep apnea who are pregnant, there is a lot of negative outcomes that occur. For outcomes in maternal OSA and preeclampsia, so now if you are diagnosed with OSA and preeclampsia at the same time, there is a 5-fold increased higher risk for cardiovascular morbidity and greater healthcare utilization. This study was done by Malhame et al. In 2022. And so what are the fetal outcomes for mothers that have OSA? So women with OSA had a 38% higher risk for preterm birth. There was also a 40% higher risk for delivering large for gestational age infants, because as we mentioned before, there are also like glucose dysregulation issues that happen from obstructive sleep apnea. There was risk for stillbirth that was increased with 25% among women who had OSA. And studies have shown significantly decreased fetal movements during apneic events at night. More than 5 times as likely to have developmental delays and ADHD, but this study had a very low power and more work definitely needs to be done on this area. And so we're going to talk a little bit about the screening tools and treatments for OSA in pregnancy. Again, I'd like to reorient us about where we are at. We've talked about the case, we've talked about epidemiology, we've talked about obstructive sleep apnea and defined it. We've discussed OSA in pregnancy and its effects on maternal and neonatal health outcomes. And now we're going to talk briefly about the screening tools that exist. First, it's important to remember that women do present differently. And women tend to not report snoring, like I've said before, and they tend to present more with fatigue and mood disorders. These differences in presentation are not aligned with our current screening guidelines. For example, the Stop Bag questionnaire has a sex bias. You get a point for being a man. The current diagnostic criteria for sleep apnea results in underrepresentation of women. We need better screening tools because there's no good screening tool that is available for women who are pregnant. In this study, they did a meta-analysis and showed all the three common questionnaires that we have, and they all showed moderate to low sensitivity. Stop bang was the best one. And as we've discussed, there is a sex bias in the stop bang questionnaire. ASS score showed the poorest sensitivity, which makes sense because a lot of women do not report a daytime sleepiness. They would say that they're fatigued. And now that we've talked about the screening tools, what if there is any benefit of CPAP use in pregnancy? This is an area that a lot has not been studied about. There are not very good trials that have been done, and I only found one randomized controlled trial that had been completed. But for the limited trials that have happened, this first trial showed that there was significant decrease in blood pressure and an associated decrease in the dose of antihypertensives for women who had hypertension and OSA who used CPAP compared to those who didn't. All treated patients had uncomplicated deliveries compared to the control. Again, this was had a small number of participants. For the second study, it was looking at gestational diabetes with obstructive sleep apnea. And for those who use CPAP, there was significantly improved insulin secretion and sensitivity, and there were lower rates of preterm birth and lower rates of unplanned C-sections, which shows that there is benefits of using CPAP. We just need a lot better, more studies to show this. This was one randomized control trial that had happened in Thailand. There were 153 participants who used CPAP and 157 participants in the usual care group. CPAP adherence was low, as we've discussed in the past about this arousal threshold. This is not surprising. And there was an average use of 2.5 hours per night. But even with this low adherence and low number of hours that the CPAP was used at night, there was significantly lower diastolic blood pressure. Preeclampsia rate was 13.1% in the CPAP group and 22% in the usual care participants. I feel like this is a very promising area that we need more research about so that we can make statements about the use of CPAP for women in pregnancy who have obstructive sleep apnea. Are there any fetal benefits of maternal CPAP use? No trials actually exist, but some small studies have shown increased fetal movement for women who use CPAP at night. There is enhanced placental perfusion, and there's a proposed support, and this supposedly supports fetal growth and reduces risk for gestational age infants. There is a mitigation of metabolic disturbances that contributes to fetal macrosomia. So if you use CPAP and that helps, then you have more normal birth weights. Again, these studies are not randomized controlled trials. There's a paucity of studies in this avenue. So what do the current guidelines say? We screen pregnant women with obesity, hypertensive disorders of pregnancy, and gestational diabetes. When do we screen? We screen in the first or second trimester. I wondered why we didn't screen in the third trimester as well, because a lot of people developed snoring, which increases risk for obstructive sleep apnea. And so I had wondered why screening in third trimester was also not recommended. What do we screen with? ASS score, stop bang score, and Berlin questionnaires were not recommended screening tools. There is a new screening tool that is coming up called the FACO screening questionnaire, but more research has to be done into the validity of this. For testing, home sleep apnea testing may be used. We do know that in-lab studies are better, but it's difficult to do in-lab studies when you're pregnant. CPAP use was recommended, not because of any benefits, because like I said, there isn't enough study that has been done, but because the potential benefits outweigh the risk. The therapy should be aimed at modifying pregnancy-specific outcomes, should not be aimed at modifying pregnancy-specific outcomes, but rather should be aimed at symptom management and objective measures. And so I'm going to talk briefly about postpartum sleep deprivation as it relates to postpartum depression and mood disorders, because a lot more has to be done on this. So sleep deficiency is a significant risk for postpartum depression. Multiple studies have shown this. And poor sleep quality in the early postpartum period independently predicts the development of postpartum depression in 3 months postpartum in high-risk samples. We need to be very much aware of this, because I feel like, when you're postpartum and you go to the doctors, no one ever asks about the sleep. They ask about mood, about, depression. They give you all the screening tools and questionnaires, but no one's ever asked about how was your sleep? There's an assumption that sleep will be bad for several months postpartum, but how does that affect the mother long term? We need to know more about this. And so there are a lot of gaps in research that I have highlighted, but I'm going to summarize again. We need more research. We need more research. We need more research. Okay? We need improved screening and diagnostic tools. Further studies need to be done to clarify how OSA drives maternal and fetal outcomes. We need better evidence on whether CPAP therapies improve maternal and fetal outcomes. And we need more studies on racial and ethnic differences in maternal OSA. It needs to be better understood. We also need to do more work to understand maternal health as a whole. And this is going to make me talk about the work that we're doing right now. So currently in Connecticut, there is a study that is ongoing. We're looking at phenotypes of sleep health among Black and Latina women of childbearing age. And this is an NIH-funded R01 study, and the principal investigator is Dr. Nancy Redica. I am part of this study group, and it's been a great pleasure working with them. What is the need for the study? I think this whole presentation has discussed over and over again the need for this study. Sleep difficulty is a risk factor for adverse pregnancy outcomes, and Black and Latina women are at elevated risk for adverse pregnancy outcomes. There is some evidence that Black and Latina women have increased sleep problems, but limited evidence on the factors that contribute to sleep difficulty. Again, so many things to discuss in sleep, not just obstructive sleep apnea, but sleep deficiency, sleep environment, so much more. The aim of the study is to first even characterize sleep health phenotypes among Black and Latina women of childbearing age and examine the associations between multiple demographics, social and behavioral factors that may contribute to the sleep characteristics. This is a mixed method study, and we're doing a lot of qualitative interviews, and there's self-reports, questionnaires, and we're doing home-based objective measurements with actigraphy. The study methods: we are recruiting 300 Black and Latina women in Connecticut's area, ages 18 to 49 years of age. They have to be non-pregnant and not parenting a child less than 1 year old, because that is a confounding factor for sleep, as we know. The consent will be collected, and we're using REDCap to collect all the questionnaires. The measures of sleep, we're using 2-week risk actigraph and home sleep studies. And what I'm doing with this study is recruitment. I do love recruiting from the community. I do like working with the community. And this has given me the opportunity to be a part of community health fairs. I go to libraries, I go to coffee shops, I go to the gym. My activity actually has like a board where you can post your research studies, and they're very open to research. So this has really made me more engaged in my community of New Haven, and it's been a very wonderful experience. The benefits: you get a sleep screening report, and then you also get a $150 gift. The current progress. We've made a lot of progress. It was a little slow during the summertime, but now we're kicking back up. We have reached out to about 325 people. We've screened 196. We've enrolled 175, and 156 have completed their surveys. We have actigraphs that have been completed, 125, and PSG completed is 126. So, we're getting there, and we need help from people in the community as well. I have flyers in front. If you have a clinic and you have women of childbearing age in your clinic that might be interested in this study, please distribute the flyers to them. We'll be very, very excited to have them. So in summary, OSA in pregnancy is common and linked to adverse maternal and neonatal outcomes. Hormonal, anatomical, and fluid changes contribute to airway collapsibility and OSA risk, but we also need more studies about non-physiological risk factors that could contribute. Racial and ethnic differences in OSA prevalence and severity is definitely not fully understood yet, and we need more studies for that. And current screening tools perform very, very poorly, and evidence on CPAP use is effectiveness, CPAP use and CPAP effectiveness during pregnancy is also limited. So we need more work to be done on this. I want to thank everybody, first off, for coming, but I also want to thank everyone that has been a part of my research journey at Yale. Dr. Yagi, thank you so much, for, especially these past few days, for all my anxious messaging and helping me throughout this presentation process. Dr. Nancy Radica for being so patient with my scheduling, inpatients and outpatients, and when I'm able to go around the community. And I also want to thank Declan Barry, Sanjun, Ehimen, Connie, and my favorite MFM, Lena Sweeney, who tells me everything I need to know about maternal health. So thank you. And a little thank you to my, to my community, for my husband for definitely taking leadership in this past few weeks while I've been working on this project, but overall throughout my fellowship and residency training. And for Wale, who told me to stop working this morning. And for my baby girl that keeps shouting, mama. Thank you to everyone. So these are my citations, and then I will take any questions that anyone has.
First, I know we have a couple of questions online as
We
well.
do?
Great job for it. It was really, really interesting and well-delivered talk, so thank you. I apologize if I missed this, but I was wondering amongst, in our health system, for example, amongst women who are diagnosed with and treated with CPAP during pregnancy, are there racial disparities regarding who gets treated with CPAP versus not? Do we know?
We haven't done any research on that. It's even within our health system. And I didn't see any research on that outside the health system as well. This is there's a lot of work that needs to be done with research.
A wonderful job. Thank you so much for talking about this really important topic. And I think one of the slides that struck me in your presentation was that where you had the randomized clinical trial of women in various stages of pregnancy, and then the CPAP usage was like 27%, 2.5 hours a night, which sounds really hard. It's like among all the other things you have to do as a woman who's carrying a child. And so I'm just trying to think in your so far in your field experience and talking with all these women, are there other sort of ideas or other things that people use or women use to treat their snoring anecdotally? And what are those things? And clearly we need something else other than CPAP for these women, if only 2.5 hours can be used.
Yes, definitely. Nothing from the questions that I've asked people, my own personal experiences, my experiences with other mothers, nothing else, no other things have been used to help with snoring during pregnancy. Even the discussion of CPAP use, like a lot of people don't even know to check to see if they have sleep apnea and, before they even get to the use of CPAP, but not a lot of information about other things that could be used. But we definitely need something besides CPAP. I can't even imagine being 10 months pregnant and needing to have a CPAP on my face, and you can't slide down flat on your back. It's dangerous. So you have to be on the side, and you wake up several times a night, even without the CPAP use, but we definitely need something else besides CPAP.
Sounds like an amazing opportunity.
Mhm.
Richard.
Wonderful presentation. What do we know about why Blacks are 2 times more likely to have sleep disordered breathing? And it was clearly shown, as you pointed out, that weight alone is not a cause. So why would that be?
Sorry, can you repeat your question?
Why would Blacks have a 2 times higher incidence of sleep disordered breathing,
Mhm.
I guess in pregnancy and otherwise,
Mhm.
when it's been shown that weight alone is not the cause? Why is this? Or do we know? What are some thoughts?
So there are some thoughts that the shape of the mouth, the jaw size, and the shape of the lower jaw could be a contributing factor, but this is no research has been done about it yet.
Sorry, I'll come join you, Kathleen. So people have looked at that question recently. There's this MESA study, multi-ethnic study of atherosclerosis, that has a diverse group of people. And what they found is that it's actually maybe 20 to 30% of that difference in AHI is due to differences in ventilatory control. So yeah, so that loop gain thing that you were talking about. So it turns out that African Americans tend to have a higher loop gain on average than, Caucasian white males. And that explains about 20 to 25% of that difference, at least in part. So there are some biological differences that seem to be the case.
Interesting.
So can I just follow to that? And I was wondering, like, are there racial differences detected in other, like, non-US populations for OSA and pregnancy or otherwise?
No idea.
I didn't see. Yeah, I didn't see in my research of what I was researching. I didn't see.
There is a question online from Dr. Singh for studies that showed a link between obstructive sleep apnea and pregnancy outcomes. Did they look at a 3% or 4% AHI definition for the definition of hypopnea? Did hypopneas with arousals also increase risk for pregnancy outcomes? Is there a difference in outcomes for those with obstructive sleep apnea prior to pregnancy versus OSA that developed during pregnancy?
Okay, we have to take it one at a time. So the first part of the question.
First part was, do they specify, do you know how they defined hypopnea in that study? Was it using the 3% oxygen desaturation or 4% oxygen desaturation?
It was using the 4% oxygen desaturation.
Okay. And do you know if hypopneas with arousals also increase risk for poor pregnancy outcomes, or is it mainly mediated through the oxygen, the hypoxia?
It wasn't specified in the study.
Okay. And is there any work that has looked at a difference in outcomes for those with obstructive sleep apnea prior to pregnancy, such as in your patient that probably had more severe during pregnancy versus sleep apnea that developed during pregnancy?
No, I specifically looked for this, and I was like, what happens if they were diagnosed with sleep apnea before pregnancy? What happens during pregnancy? Does their AHI worsen? And I didn't see any research that had been done about that. There was research about first trimester versus third trimester, but not pre-pregnancy.
Got it. Excellent. Yes.
That was fantastic. I think that you're right that there definitely needs to be an effective screening tool for pregnant women. But I'm wondering practically, since it's going to take some time to develop a validated tool, what advice could you give to obstetricians at this point to trigger a referral to our sleep center? Maybe sort of tied into that, it sounds like it's a very time-dependent referral, right?
Yeah.
Because you better do it right away or it's too late.
So we do
how would
have
you
a fast track for pregnant women in our sleep center. So the maternal fetal medicine group does know about this fast track, and they're able to send their patients and they will be seen quicker. And so this patient was actually sent through the fast track way, and they were seen, I think, in a few days.
But I guess
by
then what
doctors.
is so what's the trigger, right?
What's the-
Because
what's the
because you said
trigger?
it's depression, fatigue.
Sorry, the
But,
trigger
well,
of the symptom or?
how do they know that their patient has sleep apnea? Because the symptoms are atypical and nonspecific.
Yeah, so a lot of people are missed, and we don't have good screening tools. But now if they have preeclampsia, or if they have hypertension, or they're obese, it would trigger the referral to sleep study. And for this patient specifically, she already had a sleep study that was done before she got pregnant. So they knew she had mild OSA, and they wanted to treat it during pregnancy.
Great presentation. So I think I agree with you, this is all super important work. But my question is, once you do identify these pregnant women that have sleep apnea, that you're able to find a screening tool that is effective and identify the patients, do the MFMs treat these patients any differently solely because of the OSA diagnosis, since they are at such higher risk of preeclampsia, gestational diabetes, and adverse fetal outcomes? Do they get more stress testing, more frequent testing for gestational diabetes?
So right now, there are no guidelines to say that they should be treated differently, or they should have more fetal testing or more testing in that light. So current guidelines don't recommend that. In practice, everyone does things differently. My MFM friend, Lena, for this patient specifically, they had a lot of other things that had been going on, and they had like 3 pregnancy losses at this time. So she tests her more frequently, but there's no recommendations to.
Hi, Ofure. That was a great talk. Your talk kind of reminded me some of a class that I took when I was taking my MPH degree in med school. And I remember, overall in Black pregnant women experience high fetal complications. And I think I remember learning something about just even though it's a high income woman, just because they're Black, they experience higher complications, likely due to some microsocial aggression, structural racism, maybe some overall, some racisms, or what's it called, healthcare access, etc. I was wondering in your study if you are collecting some of those determinants too, to see if they play a role in any kind of sleep disorders in this pregnant woman.
So in our studies, sorry, can you ask the last question again? In the current study that is
In your
going on?
current study, yeah, are
Yes.
you collecting those kind of social determinants of health as well to learn about more sleep in this vulnerable patient population?
Yes, we definitely are. We're collecting information about the sleep environments, their zip codes so that we can know the geographical areas. We're collecting questionnaires about their mood, psychosocial comorbidities, and things like that. So yes, we are collecting other data.
More questions. Just a comment and observation. That was such a great presentation, Ofure. Thank you.
Thank you.
And particularly brave, because you're not a sleep fellow yet. You're a
Mm-mm.
pulmonary. We're all assuming you've done a sleep fellowship, and you have not done that. And so you've learned a tremendous amount. But I think in addition to the real need to improve health outcomes in this clearly high-risk population, what it strikes me is that particularly for conditions like gestational hypertension, for eclampsia and preeclampsia, this sort of condensed 9-month period of time represents a real unique opportunity to better understand how sleep apnea impacts cardiovascular risk. And it takes us so long to examine that when we wait years for health outcomes. And not only does it deserve better studies, and you have clearly outlined a research agenda for the years ahead. But this could really inform other domains of risk outside of pregnancy as well, using this as a model. So
Mhm.
very nicely done. Thank you.
Okay.
Any other comments? All right. Thank you very much. Thanks everyone for a robust discussion.